diploma in anesthesia, and he has done his critical care IDCC from Apollo Chennai, and he's working in Vizag. He's a very well-known and very famous critical care specialist of Visakhapatnam, and he's very dedicated and hardworking person. So I really thank Dr. David for taking initiative and taking care of this entire academic program of Morton Group for Thursday classes. Thank you, sir.
Thank you, sir, for a kind introduction. I'm going to talk on management of severe life-threatening gram-negative bacterial infections in ICU. As Mohan sir said, be positive. I want to be positive to reduce the incidence of the gram-negative infections in ICU, because it is the most common cause of death due to sepsis in Indian ICU setups. When I check the incidence of the death rate of sepsis in Indian and South Asian countries, Afghanistan is the highest, 283. Next, India, 218 per 1 lakh cases, and Pakistan is 208. Nepal is 185. Sri Lanka is around 150. So, really, I shocked after seeing this data. In 2019, death rate of sepsis per 1 lakh, India is a leading country due to sepsis-related deaths. So it is definitely it is a time to concentrate on these sepsis cases, particularly gram-negative infections causing the highest mortality and highest rate of admissions in ICU. It must be very careful to reduce the incidence of the gram-negative infections by various methods in ICU. So in that context, WHO has given the priority list of critical infections in ICU. Among the priority 1 of critical gram-negative infections are Acinetobacter baumannii, Pseudomonas aeruginosa, and all Enterobacteriaceae family, which are all carbapenem resistant, including ESBL, and presently now it is OXA48, carbapenemase, and NDMs. These are the killers of the infection. Now the second priority is MRSA and VRE, vancomycin resistant Enterococcus faecium, but faecalis is lesser than the faecium, and MRSA. Other clarithromycin resistant Helicobacter, Salmonella, fluoroquinolone resistant Salmonella, and cephalosporin resistant Neisseria, and other things. And the third group is Streptococcus pneumonia, which is penicillin resistant. So out of all these bacteria, the critical thing among in all ICU, Indian ICU setups are these 5. It is most commonly causing death in Indian ICUs. This is escape organisms: Enterococcus faecium, Staph aureus, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas, and Enterobacter E. coli. Mostly you are seeing this type of bacteria in almost all ICUs. So all of you know that the sepsis definition, previously it was SARS plus infection, now has been changed to, it is a life-threatening organ dysfunction due to infection. That is sepsis. This leads to a response from the body. The response is the 2 types. One is regulated and dysregulated. Once a person is dysregulated due to several reasons, depends on the patient age and comorbidities and his genetical predisposition, the person decides, the body nature decides whether to regulate the sepsis or dysregulate the sepsis. The person is dysregulated, then it leads to severe cytokine storm and inflammatory response, multi-organ dysfunction, finally leads to multi-organ failure and death. So we have to identify which is the person is dysregulated leads to high mortality and morbidity. Now the different types of bacteria in our ICUs of multi-drug resistant is more than 2 bacteria of a single class of more than 3 classes. Means in one class of antibiotics, there should be 2 minimum antibiotics should be resistant. At least 3 classes. Out of these are ESBLs, AMC, and XDR, extensively drug resistant. In this group, this bacteria is sensitive to only one antibiotic or 2. Like what we are seeing in our ICUs, resistant to all except colistin or tigecycline. Like that. This is extensive drug resistant. Pan-drug resistant is resistant to all antibiotics. Not even single antibiotic is sensitive to this. So, Enterobacteriaceae family, this is the most common gram-negative bacterial infections. This comes under NDM 1 and 2, New Delhi metallo-beta-lactamases, KPC, Klebsiella pneumonia carbapenemase, which is resistant to carbapenem group, ESBL, the older ESBL and the newer generation of extended spectrum of beta-lactamases group, plus AMC, enzyme producing bacteria, OXA48. This is almost 50%. Incidence is increasing up to more than 50%. Plus ESBL plus porine loss. This type of Enterobacteriaceae family is becoming threat in ICU. Later Pseudomonas and Acinetobacter. These are the non-fermenter group, which comes under metallo-beta-lactamases like venerointegrin and imipenemase producing, and the New Delhi metallo-beta-lactamases producing OXA group, efflux pumps. This is the antibiotic resistance group, AMC and porine. So what are the risk stratification? What exactly causing this resistance due to gram-negative bacterial infections? So what is the baseline characteristics of the patient? And epidemiological background and antibiotic exposure and colony forming in that person, and what are the catheters causing the infection. All these 5 things take into consideration to identify the risk of the person who develops the resistant bacterial infections. Among these, age more than 70 years, diabetes, and Charlson index score of more than 3, and recurrent urinary tract infections, use of corticosteroids, immunosuppression patient, and post-transplant patients, trauma, polytrauma or head injury, malignancy, organ transplantation, COPD, neutropenia, and recent exposure of surgery. This is the risk factors. Epidemiological background. Patient comes from the other hospital or previous admission, less than 12 months, prolonged hospitalization, and transfer from one health center to another healthcare. Current or prior ICU admissions, local epidemiology, any outbreak in the society, or high endemic zone. Exposure of the antibiotic less than 3 months, recent aminopenicillin exposure, cephalosporin exposure, fluoroquinolone exposure, carbapenem exposure, and the aminoglycoside exposures. Prior colonization, any colonization of the ESBL, CRE, MRSA, Acinetobacter, or endotracheal of the Pseudomonas in the previous admissions, or any colonizations. Indwelling catheters, urinary catheters, tracheostomy tubes, nasogastric tubes, CVC, patient on mechanical ventilator, hemodialysis. Any of these things having the patient, that should consider as this patient having high risk to develop the infections. So to risk stratify, to develop the antibiotic stewardship or to start which type of antibiotic in that person, you can divide into 4 types. Community acquired infections, healthcare associated community associated infections, nosocomial infections with risk of invasive fungal infections. So the first group is no contact healthcare system. Is a young man, no comorbidities, no antibiotic exposure, and that person develops any sepsis in the community level, whether patient is in very severe septic or stable, or patient is very critically ill. It is not because of the drug resistant infections. It could be due to virulence of the bacteria that causing the severity of the infection.
ఒక నిమిషం అయితే నేను వెళ్ళి వచ్చేద్దాం మమ్మీకి రమ్మను.
Hello? Sir, mute చేయండి. Type 2 is the contact with healthcare or previous admissions or patient coming from the another nursing home and CAPD or minimal invasive procedures. Antibiotic exposure less than 90 days and patient more than 65 years. And these patients having the risk of developing ESBL and MRSA. And there is very minimal chances of having invasive fungal infections. Type 3 patients are nosocomial infections. Hospitalization more than 5 days with invasive procedures, recent or current use of multiple antibiotics, multiple comorbidities, including neutropenia and severe immunosuppression. These patients having high chances of MDR and XDR infections like ESBL, MRSA, and non-fermenters like Pseudomonas and Acinetobacter. And they have high risk of developing invasive fungal infections which are undergoing allogenic bone marrow transplant, liver transplant, and patients having chemotherapy or neutropenic patients. These patients having high risk of MDR, XDR, and invasive fungal infections. Type 4 patients are having high antibiotics and are not subsiding the fever. And there is after removal of the control of the source, still patient is febrile, septic, and with septic shock. These patients having on TPN, immunosuppression, and major abdominal surgery, and multifocal candida colonization, and diabetic patient. This patient is very high risk and who are likely to develop pan-drug resistant and high chances of invasive fungal infection. So risk stratify these type of patients and see the antibiogram and local local epidemiological background and select the antibiotic or antifungal depends on the patient condition. So coming to the evolution of the beta-lactamases production of resistance pattern, the wild type of bacteria, wild type means the natural bacteria which develops a resistance pattern by developing the plasmids or enzymes and genes that develop the resistance is initially penicillin resistance, later beta-lactamases, the old generation of beta-lactamases like TEM1, TEM2, and SHV. Later, new generation of the beta-lactamases like ESBL, CTXM, and SHV and TEM. Later, carbapenemases, KPC, metallo-beta-lactamases, and OXA48. These type of enzymes produced by this bacteria by developing various mechanisms of the antimicrobial resistance. So the first generation, later ESBLs, AMPC, and metallo-beta-lactamases. Finally, the carbapenemase resistant to bacterial infections. They are sensitive to astrinam, polymixins, and EDTA and the ceftriaxone. So the various generations of developing the genes or enzymes to develop the resistance. We have to identify the genes and the enzymes that produced by this gram-negative bacteria so that we can select the correct appropriate antibiotic to prevent the resistance pattern. So this is the various mechanisms of the antimicrobial resistance for various antibiotics. So our concentration is on efflux pump and beta-lactamases group, porins, and lipopolysaccharide. Lipopolysaccharide lipid A, because the colistin acts on the outer membrane of the gram-negative bacteria. Once the outer membrane, the lipid A will be modified by this bacteria by plasmid mediated MCR gene expression. This is the resistance mechanism of the colistin resistance. So all these type of bacteria having different various mechanisms. MCR1 gene and the lipid A modification, MGRB genes. Now recently these genes are identified for colistin resistance antimicrobial. So the Ambler classification of various beta lactamases is broadly divided into serine beta lactamase and metallo beta lactamases. Serine beta lactamase group A, C, and D. Metallo beta lactamase is class B. In class A, the older generation, initially penicillinases and beta lactamases, STEM and SHV, and new is new TEM and SHV, CTXM and KPC. KPC, Klebsiella pneumonia carbamazepinamases is not common in India, whereas other groups are very common. AMC, OXA48, NDM1, NDM2, metallobeta lactamase, and WIM. So these broad classification is divided to see what type of beta lactamases to select the antibiotic. So causes of deadly multi-drug resistant infections in India is most commonly is Klebsiella, which is XDR or PDR. Mostly it is MDR, E. coli, and Pseudomonas acinetobacter. So others like MRSA are very less, 4 to 5%. Enterococcus faecalis is only 4%. The overall gram positive is maximum 10%. The rest of these things are gram negative. Unfortunately, the colistin resistance is increased up to 37% in this study done in Chennai. So 37% of Klebsiella even become colistin resistant. The OXA various 11 types of enzymes variants are identified in OXA group. This is up to 50%. Not only the OXA groups, they also develop the ESBL, NDM, and WIM and become resistant to even colistin. In that context, the mortality is increasing very high. So my purpose of telling all these things to identify the genes developed by the bacteria to select the antibiotic very early and appropriately so that to prevent the mortality and the resistance. The WHO given a red signal and ICMR identify the 5 types of the deadly gram-negative bacteria, E. coli, Klebsiella, Pseudomonas acinetobacter, and the Staph aureus, which is causing the very high mortality, and it is given red signal and warning to all the Indian ICU and Indian associations to reduce the incidence of the bacteria by taking proper antibiotic stewardship. In colistin resistance gram-negative bacteria, the MCR1 gene that is causing the resistance has been increasing from year to year. Now it is going up to 50%. Now I will take one case scenario so that we can take a decision to start an appropriate antibiotic depend upon the patient condition. A 55 years old male patient who is diabetic, COPD, and CAD, who undergone CABG 5 years back, and who admitted with acute onset of breathlessness with high-grade fever, and came to ER, and the patient in ER he worsened. This patient on initially on NIV worsened, then intubated. This is the X-ray having bilateral lower zone opacities, having pneumonia. And what would be the next step? So how will you proceed this patient? As per the sepsis protocol, we will take the blood cultures first and send the lactate levels, routine investigations, and then you assess the risk of MDR infections. Depends on the patient comorbidities and local epidemiology. And what is the resistance pattern from which hospital patient has come, what is the local antibiogram in that area. That should be in mind. Because patient is very sick, patient going into septic shock, rapidly deteriorated, coming from another hospital. Usually, routinely, we will start the meropenem and vancomycin, thinking that meropenem will cover all the broad spectrum gram-negative and some gram-positive, and vancomycin will cover gram-positive and the MRSA. So, patient is shifted to ICU, day 5 in ICU, but patient is not improving, his oxygenation is coming down, and his temperature is going up, and counts are worsening, and the X-ray is worsening. Patient is having worsening bilateral pneumonia and going into ARDS. Then we did a ball culture, sent for the culture. So we wasted 5 days by doing our routine type of antibiotics, like what you thought in the higher antibiotics, meropenem and vancomycin, but patient is not improving. Because it takes more time, 3 to 5 days, to get our traditional type of antibiotic culture sensitivity reports, like drug sensitivity test, DCT, which is fastidious and more difficult to identify the gram-negative and gram-positive resistance pattern particularly. And the turnover time is very high, 3 to 5 days. The patient will not give that much time to take another decision. And we need some panel to identify the bacteria or virus or fungus very fast, and the turnover time should be very low, and it needs high sensitivity and specificity to identify the drug resistant genes, particularly to select proper antibiotic, to optimize the treatment, to reduce the cost and reduce the resistance and the mortality. So what the diagnostic panel tools are available presently in the world is agglutinin assay, which is very less time, within 5 minutes you will get the report. FISH, 1 to 2 hours, and the RT-PCR, which is the most commonly used now in India, and the multiplex RT-PCR gene expert technology that will give the report within 4 to 6 hours of time. Cost is around 30,000, and the system will generate the reports. Next generation sequence, next MultiTop, which is also available in India in few centers, that will give within 5 minutes. So as soon as patient admitted and even in the ER, you can take a decision to start appropriate antibiotic, broad spectrum antibiotic, to prevent the resistance as well as the mortality. So Carba or flagged blood culture samples can be detected the carbapenem resistant genes to whether the patient is resistant to carbapenem or not. And there are the genes OXA48 or NDMs can be identified within 5 to 6 hours. This is the study done by the Chennai Apollo Hospital group. They identify NDMs are 32% and OXA is 50%. And both the NDM and OXA is around 15%. So after 5 days, our patient report has come that shows sensitive to Klebsiella pneumonia, sensitive to only colistin and phosphomycin. So our antibiotic was meropenem and vancomycin, but the day itself we send the cultures are resistant to all antibiotics except colistin and phosphomycin. That is the reason why a patient is deteriorating, and the the gene expert technology shows that it is OXA48, which is sensitive to Septaginum and Avibacter. So we could have taken decision initially by putting the Septaginum Avibacter instead of the meropenem and vancomycin, to prevent the further deterioration. So in the MDR scenario, when patient is resistant pattern, the drugs available is very minimal, and there is no new drugs are available in the pipeline. All are exhausted, and getting day by day resistant pattern in the ICU, and no new antibiotics are available. In that scenario, now they are advised to increase the dose, double the dose, like tigecycline 100 milligrams BD, and polymixin with the tigecycline plus carbapenem combination, and the carbapenem high dose with prolonged infusions, and the new drugs are yet to come in the market. These are all eravacycline, plasmamycin, and meropenem verbobactam, imipenem relibactam, and cefdorolocol. These are the doses are here. I will send this PPT in our groups to see the doses. So, a ceftazidime avibactam will not be sensitive to Acinetobacter baumannii and NDM. Whenever the patient is sick, to identify what bacteria, what is the bug likely to causing this infection, what is the antibiotic to be selected is to identify the genes that is causing the resistance. If you start the patient which are started this antibiotic, which is NDM, then this ceftazidime avibactam will not work if it is NDM or Acinetobacter baumannii. So keep it in mind that before starting this antibiotic, whether it is NDM or it is Acinetobacter. So the polymixins are now available, the last resort drug once they develop all the multidrug resistant or XDR bacteria. This is the only option available. How it acts? It is having a detergent action on the cell wall, and it binds the outer membrane of the phospholipids, particularly lipid A polysaccharide, and it break the cell wall, and the inner contents leaks out, and then cell death happens. This is the way of killing the bacteria by using the polymixin group. The polymixins will cover all this bacteria except gram positive and some intrinsically resistant to Proteus and Salmonella, Shigella, and the Neisseria, and all this type of bacteria which is intrinsically resistant, Burkholderia. So if a Burkholderia is there, this colistin will not be proper drug to start because intrinsically it is resistant, and which is sensitive to MDR, XDR, Enterobacteriaceae group, and non-fermenters like Pseudomonas and Acinetobacter baumannii. The major difference between these polymixin and colistin is polymixin is a more potent, but clinically both are same. Polymixin B is a active drug which will not be converted to anything, but whereas colistin is a polymethate sodium, colistin sulfate, methate sodium, which will be converted to active drug. So the four drug will be converted to active drug. You don't know how much will be converted. It depends on the various pharmacokinetics varying from the one person to another person. So the drug dose is will be very high to prevent the resistance. That's why nowadays they are giving colistin for sensitivity, intermediate sensitivity I. They are not giving full sensitivity report. So the dose adjustments is not required for polymixin B, whereas dose adjustment is required in case of renal failure. Loading dose should be given whatever the renal failure, followed by dose adjustment depend upon the creatinine clearance. Nephrotoxicity is less when compared to the colistin. The polymixin is around 11%, colistin is around 40%. So the elimination is mainly by renal for the colistin. So colistin is the best drug for the renal means urosepsis. The dose adjustment for the creatinine clearance values. So whenever the patient comes, depends upon the clinical scenario. See the what type of patient history and clinical examination, so that we can see whether urinary tract infection, intra-abdominal nosocomial pneumonia, or bacteremia. Find out the associated comorbidities, whether diabetic, COPD, or any liver renal disease, immunosuppression, neutropenia, elderly person, cancer, organ transplant, or a patient on hemodialysis. Whether risk factors for carbapenemas and ESBLs, like previously any colonization, previous use of broad spectrum antibiotic, any invasive lines, previous ICU admissions, and epidemiology, and the coming from the endemic area of using the Enterobacteriaceae, and local epidemiology, like a local ICU scenario, or your ICU is resistant with carbapenems, having more Enterobacteriaceae, more ESBLs. Then you select the empiric antibiotic. Before you select the empiric antibiotic, if it depends on the ESBL or carbapenemase group, you need to have certain diagnostic tool to identify very quickly to prevent the resistance. Suppose here the empiric therapy is ceftazidime avibactam, but if the patient is having NDM or MCR genes, it won't work. We have to go for a different protocol to select the antibiotics. So rapid diagnostic tools are nowadays necessary to identify these genes, resistant genes, and the bacteria or even fungal very rapidly. Once you suspect the sepsis, look for the risk factors for the MDR, XDR, and then monitor the procalcitonin levels and radiological evaluation, send the cultures, and look for any previous MDR colonizations. If it is ESBL or suspecting ESBL, CRE, the ESBL, the drug of choice is meropenem. For example, once the patient comes to ICU with a urinary tract infection with hypotension, we will give fluid registration and take the cultures and start routinely a BLI group like piperacillin tazobactam or cefoperazone sulbactam. But if it is ESBL risk, it won't work. We have to straight away start meropenem the first day itself to prevent the deterioration and the resistance or even mortality. If it is CRE, carbapenem resistant Enterobacteriaceae, again the meropenem won't work. Either you have to go for ceftazidime avibactam or colistin. But to start whether it is ceftazidime avibactam or colistin, again we should know whether it is NDM or not. Even if it is not NDM and there is a MCR or another type of resistance for colistin, then you have to identify again the MCR genes and the MGR genes and the modified type A polysaccharide to identify the colistin, even colistin resistance also. Why? Because what is our routine practice in the antibiotic protocol, antibiogram is, we are starting BLI group like cefoperazone sulbactam, like Magnex or Piptaz, all these drugs. Once the patient is not improving, then we are switch over to meropenem or targocid or vancomycin, this type of drugs. Since that patient is not improving, later after 3-4 days, we are switch over to colistin or tigecycline and starting the antifungal like higher antifungal drugs. By the time patient is deteriorating and not improving, so in that scenario, instead of wasting time up to 5 days to 1 week to allow the patient to die, we have to identify these genes which are causing the resistance, and we have to identify the bacteria which is the multi-drug resistant or pan-drug resistant to select a proper antibiotic very early, initially, when patient is very sick. Otherwise, we have to accept the mortality. That may be the reason why in India, the mortality when compared to even our surrounding countries is very high, almost equal to mortality in Afghanistan. This is very pathetic situation. All the intensivists working in ICU should think about this resistance pattern. The only thing is to identify early and start early appropriate antibiotic. Whether it is some people may say in ICU, other consultants, why you are starting very high antibiotic very early. It is not like very high antibiotic, costly antibiotic very early as soon as patient comes to ICU. It is my definition of starting of antibiotic is early appropriate antibiotic which likely to cover the what is the causative organism causing this sepsis. That is the main goal of starting this any type of antibiotic, whether it is low or high, doesn't matter. So these are the various options of treatment, depends upon the various group of organisms. ESBL is one option, CR is one option. If it is Pseudomonas is another one or two options. If Acinetobacter is these are the drugs available. These are the protocols. So we can select depends upon the underlying pathology. When compared to the polymixin B and colistin, there is no significant difference. Both are equally effective. But for urinary tract infection, you can select the colistin. For other infections, you can select polymixin B. So for multi-drug resistant or pan-drug resistant, this is a carbapenem resistant and the aminoglycoside resistance and polymixin resistant. All these resistant works, the scenario is to whether it is KPC or whether it is NDM or WIM, whether it is class D group of Ambler classification of OXA48 or carbapenemase group. So carbapenemase, so you with all these genes or the enzymes can be identified by gene expert methodology of multiplex PCR technology. So immediately you can divide what type of group it is and select the antibiotic. If it is KPC, you can start ceftazidime avibactam or the new drugs like meropenem, verobactam or imipenem, relibactam. Plus or minus double carbapenem coverage like doripenem and imipenem. And if it is NDM, nudily beta lactamase and WIM, can start ceftazidime avibactam combined with astrinam. Class D, if it is OXA48, only ceftazidime avibactam is sufficient. If it is carbapenemase group, can start ceftazidime avibactam, meropenem, verbobactam, or imipenem, relibactam. And these are the new drugs available, which are not available in the Indian markets: plasmamycin, ceftirolocol, eravacycline. These are meropenem, verbobactam, imipenem, and relibactam. These 5 drugs are yet to come, and that may be more helpful to start if patient is pan-drug resistant to bacterial infections. For Pseudomonas, the mechanism is carbapenem resistance, and you should know whether it is carbapenemase negative or carbapenemase positive. If it is carbapenemase negative, ceftazidime avibactam is sufficient. If carbapenemase positive, and we have to again evaluate whether it is MBL or not. If it is non-MBL, you can start ceftazidime avibactam. If it is MBM, metallo-beta-lactamase, ceftriaxone, phosphomycin, or high-dose amic acid, having some synergetic combinations. So, to differentiate the various resistance mechanism produced by various genes, identification is very important to start the proper antibiotic to works to that particular bacteria. These are all various antibiotics and either new generation and already available drugs available in the markets, and various doses depends on the bacteria doses there that I will send the PPT. You can see the doses before starting the antibiotic. Bloodstream infections, hospital acquired pneumonia, and VAP, abdominal sepsis for MDR, XDR, and PDR infections. So it particularly whenever you see the MIC levels, you see whether it is sensitive or resistant to meropenem. If it is meropenem sensitive, it will be less than 4 milligrams per liter. If it is more than 8, they will give resistance. If more than 16, it won't work. But if less than 16, one protocol is there. If more than 16, another protocol is there. Depends on the MIC levels of the meropenem, we can select the antibiotic. This is for urinary tract infection and complicated skin and soft tissue infections. So, by summary of my topic is, there are few drugs available for XDR or PDR infections like ceftazidime avibactam, polymixin B or colistin, and aztreonam. These are only 3-4 drugs are available for XDR infections. To identify the person and the risk factors on the epidemiological background, early detection of the genes to detect the bacteria and the resistance pattern, whether it is ESBL or AMC, KPC, or OXA48 or NDM or MCR1 to MCR5 genes to prevent the resistance pattern to early and fast recovery of the patient. And the final most thing to prevent the infection by taking proper preventive methods in ICU, mostly the hand wash technology and the hand hygiene protocol, and make all the ICUs to take proper precautions to prevent the infections instead of deteriorating the patient by developing the MDR, XDR infections in ICU itself. So one is identification is very important. Later, prevent the infection from one patient to another patient and make the our life is very miserable. A patient is coming with head injury and finally dying with sepsis and septic shock. That type of situations should be prevented in the ICU to take proper precautions to prevent the infections and proper identification of the bacteria to take appropriate antibiotic to improve the outcome. So thank you very much. Hello,
Sir,
sir.
David garu, extensive talk, sir.
Extensive coverage.
Coverage.
Sir,
Doubts?
if suppose Burkholderia and Strenotohomonas, which is the antibiotic of choice for this organism, sir?
Burkholderia and the Strenotohomonas, trimethoprim sulfamidaxol is the drug of choice, sir, because colistin having intrinsically resistant to these drugs. Even meropenem also can be used.
So suppose patient is allergic to cotrimoxazole, we can use meropenem.
Yes, sir.
Thank you, sir.
And Serratia also is resistant to colistin, even meropenem. And Serratia, ampicillin is the drug of choice for Serratia. So we may think that patient is a meningitis, unconscious, septic. We are thinking that meropenem, vancomycin, colistin, everything is going, but it won't respond because it is sensitive to only like ampicillin. This type of things intensivists should know, because even the small antibiotic, even penicillins will save the patient life, or higher colistin or tigecycline may not improve the sepsis. So identification is very important. That is the present trend of treating the bacteria sepsis. Identification should be very early. So I emphasize on all the intensivists in this group to use the gene means multiplex PCR gene technology. It will turnaround time is very 5 to 6 hours. Rapid identification and the rapid initiation of the appropriate drug is my conclusion in this topic.
చిన్న రిక్వెస్ట్ డేవిడ్. హలో డేవిడ్ సార్,
చెప్పండి సార్.
ఇప్పుడు పేషెంట్ వెంటనే వచ్చారు, ఒక బర్న్స్ పేషెంట్ లేదా ఎవరో, యూ విల్ గెట్, ఇప్పుడు మన మోహన్ అడిగినట్టుగా బర్కల్డేరియా ఏదో గ్రోత్ అయింది, బట్ పేషెంట్ కి ఫీవర్ లేదు, హైపోటెన్షన్ లేదు, మరి యాంటీబయాటిక్ స్టార్ట్ చేస్తామా స్టార్ట్ చేయమా?
It all depends whether it is pathogen or just it is whatever. Even we test, we will get pseudomonas in our nose or MRSA, sir. It doesn't mean that to start the antibiotic unless patient is.
No, I'm not talking about ourselves. I'm talking about the patients in the hospital in ICU.
Even patient in the ICU, whether it is a commensal or it is what you call just if it is not pathogen, counts are normal, patient X-ray is normal, patient is hemodynamically stable. Even if you get that is the commensal, it may not be a pathogen. You need not start antibiotic unless it causing the clinical deterioration. What do you say, others? మిగతా వాళ్ళు ఉన్నారా?
సార్ మీరేం ఫాలో అవుతున్నారు అని అడుగుతాను. నాకు అంటే మీరు ఎవరు యాంటీబయాటిక్స్ అంతే కదా?
ఇవ్వండి సార్. అవును,
అంటే కరెక్టే అనుకుంటున్నాను, బట్ స్టిల్ నార్మల్ నేను కూడా వద్దనే అంటాను. మెయిన్ గా మన దట్ ఇస్ మెయిన్ కదా. Everybody,
in that scenario,
what I have noticed is everybody nowadays in critical care, ఒక్క నిమిషం మోహన్ రావు, what I have noticed is whether we start treating or something, one very margin is there, we are really worried about the patient. So in the thinking of worried about the patient, we early start antibiotics or multi-drug, whatever it is, but very difficult to really decide because it's becoming individual choice. There is no real protocol, practically very tough to decide అని అనిపిస్తుంది. అందుకని అడిగాను సార్. చెప్పండి సార్ మోహన్ రావు గారు.
అంటే in that scenario, sir, in the patient has grown Acinetobacter, is not having any fever, counts are normal, CRP is normal, and hemodynamically stable. We don't know whether while sending the sample it may be contaminated. So we should not consider that positive report to start the antibiotics, sir.
జక్కినా లేడా సతీష్?
చెక్కిన ఫ్లైట్ లో ఉన్నాడు. సతీష్ ఎక్కడ తెలియదు.
ఉందా సార్ డౌట్?
డేవిడ్కి క్వశ్చన్స్.
అక్కడ అనురాధ మొదటి నుంచి మొదలు పెట్టింది. అనురాధ రాణి మేడం ఉన్నట్టున్నారు.
ఏంటి
క్వశ్చన్ అడగడానికి సార్?
ఏది? హలో మేడం.
హలో డేవిడ్.
చెప్పండి మేడం.
డేవిడ్, మోహన్ సార్ అన్న సినారియోలో హై రిస్క్ ఆఫ్ డెవలపింగ్ infection, burns case, they are growing something. So even like broad spectrum like a simple antibiotic kuda start cheyakundane untara in practice?
అదే ప్రాక్టికల్ గా మేడం వాట్ ఈస్ ఎగ్జాక్ట్లీ హ్యాపెనింగ్ ఇన్ ద ICUs? There is some antibiotic is going on in the Barnes patient or any patient coming to particularly ICU, suspecting some infection and starting antibiotic. Most commonly used is cephalosporins or BLI group like cefoperazone sulbactam or piperacillin tazobactam. This is the commonly using antibiotics. ఇప్పుడు సార్ అడిగినట్టు బర్కులరియా సెపేషియా అలాంటిది వచ్చింది, లేదంటే ఎస్నోటోబాక్టర్ ఈస్ గ్రోయింగ్ in the wound. If Acinetobacter is growing in the wound, unless otherwise patient, it may be a contamination. So unless patient is growing in the blood or growing in the other areas, not just for simple routine continuing a simple antibiotic is not the. But practically everybody is giving. Everybody is giving Tazac or Magnex or something else, or even Meropenem.
But to tell you frankly, David, even though I used to practice, but recently in our this one, even the 60% burns or 30% burns, we literally stop all antibiotics. We don't give even simple antibiotic also after one day. Because Zero is very dead against antibiotics, because he says that this is the common once after 1 week, second week onwards, giving antibiotics becomes difficult when you start now. So don't give, it literally stops, and we also accept because we closely monitor for WBC, peripheral smear and temperature. We really, that was a surprising and routine. Normally what happens is any patient coming to ER, just like IV fluid, one antibiotic has become a normal, common this one. ER once comes, definitely Lysept or something, something will be going on to the patient without any, nothing, just one antibiotic is going like that, like MI patient, the clopid is going. So that is what is happening in ER. That automatically continues for some time in hospital. So that stopping of antibiotic is a very crucial decision. It is a tough decision, I thought. That's the reason I asked. Do you agree with me, Ron?
Yes, sir. Yes, sir. Totally, I'm agreeing, sir. Because it is
antibiotic.
so that patient actually has grown Acinetobacter, but is none of any fever, is ambulated, is completely normal. So maybe we don't know now the lab sample is contaminated. Well, they're sending the sample. This is not considered. Now, if suppose patient is really having Acinetobacter, by this time he is having, you develop fever, hypotension, something, some signs are will be there. That is people will tell that treating physician is the right person. In spite of the lab reports, the right person to decide whether to start antibiotic, which antibiotic, and when to start and when to stop.
Sir,
Yes, sir.
question, sir, మీకు ఇప్పుడు one patient came from some other hospital on ventilator, విజయనగరం నుంచి అనుకోండి. Patient is came with noradrenaline, and patient is already started on some BLI group, Tazac ఏదో ఉంది, and other medication something is there. Will you send the gene expert for this biofile? బాగున్నారు గారు. హలో హలో
సార్ చెప్పండి సార్.
సార్ సెప్టిక్ షాక్ లో ఉన్నాడా, కార్డియోజెనిక్ షాక్ లో ఉన్నాడా?
Whatever the shock, doesn't matter. Once patient came from other hospital, whether is patient on
Whatever it may be, sir, we have to take this.
అంటే మీరు సెప్టిక్ షాక్, కార్డియోజెనిక్ షాక్, ఓకే, యూ విల్ డిఫరెన్షియేట్. నేను కాదంటలేదు, అది సెప్టిక్ పేషెంట్ అనుకోండి, సెప్సిస్ స్టార్టెడ్.
పంపిస్తాం సార్, we'll send.
అది how many we send that biofile? Usually you are sending for all these patients?
Sir, if patient relatives are agree for that amount of cost, we are sending, sir. Suppose patients that markers, other infective markers are high and really is in septic shock, we advise the biofile.
Okay. That's what.
Sir, sir. We are sending, but cost we have to tell the relatives. That is why they are charging around 15,000, 14,000, I think.
14,000 for
Biofed.
liver labs.
Rivera labs.
ఏంటది?
యాక్చువల్లీ బిఎంసీ లో కూడా చేస్తారండి సార్, విత్ ఇన్ 3 hours లో కరెక్ట్ టైంకి పంపిస్తే
చేస్తారంట సార్.
తక్కువ రేటు కూడా.
బిఎంసీది అంత కొద్దిగా రిలయబిలిటీ ఎలా ఉందో చూడాలి సార్ ఒకసారి.
స్టాండర్డ్ ఉంటుంది సార్.
5 ml ఒక కంటైనర్ పంపారు, దాని మీద సెప్టిక్ ఏదో ప్యానల్ అని రాసింది. That is around 7,000 they told. So they said they will give within 4 hours report. అది బయోఫైర్
because our neuro people also meningitis panel they are sending sir, VMC and Rivera lab. Through this we are actually able to identify a few rare infections also. Epstein-Barr virus, the case Suresh garu case
CSF
good actually. Yes sir, CSF
for all patients.
He is sending for meningitis patients. If patients are affordable, we are sending CSF also to the VMC or a Rivera lab. Rivera lab is actually giving more and more. It is covering the more the infective bacteria and viral panels compared to VMC.
Okay. But we have to prepare our primary consultants' minds for this type of sending this.
Exactly.
Otherwise, they don't accept. If you ask,
yes,
a sister will ask the primary consultant whether to send or not. They immediately say no. Magnets పెట్టాం కదా చూద్దాంలే అంటారు. తర్వాత వాళ్ళు మెరే పని రాస్తారు. ఏంటి సార్ ఇప్పుడు పంపిద్దాం అంటే ఇప్పుడు వాళ్ళ దగ్గర డబ్బులు లేవులే చూద్దాం అంటారు. ఫైనల్లీ మేడం
PCR టెస్ట్ 5-6 hours లో రిపోర్ట్ వస్తుంది అన్నారు. ఎక్కడికి పంపించాలి? అది ఏ ఊర్లో చేస్తున్నారు?
విఎంసి విజయ మెడికల్ సెంటర్ చేస్తున్నారు. అండ్ ఇంకోటి ఏంటి సార్ అది వాళ్ళు చేస్తున్నారు. కానీ హైదరాబాద్ బాంబే వెళ్ళి అది మనకు రిపోర్ట్ వచ్చేసరికి దే ఆర్ టెల్లింగ్ విత్ ఇన్ 24 hours.
Rivera is taking 24 hours madam. VMC I think 6 hours అంటున్నారు.
వైజాగ్లో VMC only have this facility.
Lalpath sir, Lalpath also is doing I think.
Ampath Lalpath చేయట్లేదు. Ampath also sending to Bombay. They also taking time. ఎందుకంటే
పంపించారా?
మేము పంపించాం మేడం, కొన్ని కేసులు పంపిస్తున్నాం.
వాళ్ళు ఎలాగా కాస్ట్ ఎలాగా VMC లో
చార్జా? హలో,
కాస్ట్ సేమ్ అనుకుంటాను మేడం, 13,000 అనుకుంటాను.
VMC యాక్చువల్లీ 7,000 సార్.
ఏది 7,000 VMC?
మనం 2 days బ్యాక్ పంపించాం ఒకటి 7,000.
ఒకసారి వాట్ వి కెన్ డూ ఇస్ VMC తో శాంపిల్ ను మన ఓన్ ల్యాబ్ లో ఒకటి పంపించి అలా కూడా చెక్ చేసుకోవచ్చు కదా.
యాక్చువల్లీ దట్ ఈస్ ద మేడం, that is the protocol to do. One sample we have to send to this type of test, and one sample blood cultures we have to send. We should not only depends on this lab, because culture sensitivity MIC values we have to check. No, that is only Vitec 2 will do that. MIC, you know, only genes. What are the genes and resistance patterns we will understand, but drug sensitivity levels and MIC levels should be done only in the lab, our lab.
I think next time we try to send to VMC and our own lab and we can check how it's coming.
Yeah, because after 3 days you will get the drug sensitivity levels and MIC levels, no? So that dose also we can adjust.
Okay, David. Thank you for nice class.
Thank you, madam. Okay, sir. We will close the session. Thank you for your present active participation.
Thank you, David.
Thank you, sir. Bye.
Thank you, David, sir.
థ్యాంక్ యూ అనురాధ.
థ్యాంక్స్ అన్న, బాయ్.
ఏంటన్నా నువ్వు కామకుండా
కొంచెం బాగాలేదు అందుకని.
బాగాలేదా? ఓకే అన్న, టేక్ కేర్. సార్, ఆల్ ది బెస్ట్ ఫర్ యువర్ presentation. అవును సార్.